for this carcinoma of gallbladder is Chile, which is a South America. In India, the most common location in India is North India, especially the Northeast India, has higher incidence of carcinoma of the gallbladder compared to the South India. Here, females are 3 times more affected than males. Gallbladder diseases are more common in females. So females are 3 times more affected than males. And the median age is 60 to 70 years, which is 7th to 8th decade. So this is the age in which carcinoma of the gallbladder is more common. So when you look at the risk factors, because it is one of the complications of the GB stone. So a GB stone of more than 3 centimeter is prone for the carcinoma of the gallbladder. That is why Bailey gives more than 3 centimeter is the criteria for prophylactic lap cholecystectomy in a asymptomatic patient. But according to Savistran, if more than 2.5 in asymptomatic patient, prophylactic lap cholecystectomy can be done. But when it comes to malignancy, GB stone of more than 3 centimeter has a higher risk factor. And can anybody tell other risk factors for carcinoma of gallbladder from the previous classes?
Abnormal pancreaticobiliary channel.
So abnormally long pancreaticobiliary channel because it causes choledochal cyst. So choledochal cyst is also a risk factor for the development of both CBD cancer also and the gallbladder cancer also. And primary sclerosing cholangitis is again a risk factor, especially if primary sclerosing cholangitis is associated with inflammatory bowel disease. Is a risk factor for development of GB cancer. Also, a GB polyp, right? Interestingly, if there are multiple polyps in the GB, where there is GB polyposis and all the polyps become less than 1 centimeter, all of them are within 1 centimeter, that is not considered to be a malignant risk for development of GB carcinoma. But the carcinoma, to produce carcinoma, obviously it has to be an adenomatous polyp, and this is the most common polyp. So it has to be an adenomatous polyp, and this adenomatous polyp, if the size is more than 1 centimeter and it is a single polyp in a patient of age group of 50 more than 50 years, so this increases the risk of GB carcinoma. And as the size increases, it is not the number. As the size increases, the risk increases. That is why a GB polyp of more than 1 centimeter is again a risk factor for development of carcinoma of gallbladder, and thus is an indication for prophylactic lap cholecystectomy in a patient. Now, you have a patient with GB polyp. So, if the polyp size is more than 1 centimeter, you proceed with lap cholecystectomy. So you remove the gallbladder. If the polyp is less than 1 centimeter, you evaluate the patient for primary sclerosing cholangitis. If primary sclerosing cholangitis is positive and it is less than 1 centimeter, you still go ahead with lap polyp. So the indication for lap cholecystectomy in a GB polyp for less than 1 centimeter is the presence of the primary sclerosing cholangitis because it is an independent risk factor for development of carcinoma gallbladder. If primary sclerosing cholangitis is negative, you can just have a annual surveillance. Every year, you get a ultrasound or CCT done and surveillance of the patient is done. So GB polyp of more than 1 centimeter, a single polyp in a age group of more than 50 years, and the polyp to be adenomatous polyp is a risk factor for the development of the carcinoma of the gallbladder. So these are all the risk factors. The GB stone of more than 3 centimeter, abnormally long pancreaticobiliary channel, presence of choledochal cyst, the primary sclerosing cholangitis, and the presence of gallbladder polyp. So when you look at the histopathological examination of this gallbladder tumor, so this tumor, obviously it is a adenocarcinoma because it is gallbladder is lined by columnar epithelial cells. 90% of them is a adenocarcinoma, which is most common. One more, the most important risk factor that I did not mention is chronic cholecystitis. because anywhere there is a inflammation in the body, which is chronic inflammation in any part of the body eventually leads to malignancy. Because when the cells get inflamed repeatedly, the cells undergo dysplasia. That dysplasia will lead to carcinoma in situ. Carcinoma in situ eventually leads to invasive carcinoma. But sometimes when this dysplasia, before the dysplasia happens, or even without dysplasia happening, when the cells undergo irritation, a lot of times the cells change their morphology and they become metaplasic. So dysplasia leads to carcinoma in situ and invasive carcinoma that leads to adenocarcinoma. But sometimes if there is a metaplasia, one of the good examples for metaplasia is development of Barrett's esophagus. So similarly, if there is a chronic cholecystitis, chronic inflammation, cells instead of undergoing dysplasia, they become metaplasic where they are replaced by the squamous cells and thus they can also lead to the squamous carcinoma. Right? Though rare, it is not unheard of. So about 10% of the tumors of the gallbladder can be squamous cell carcinomas. But the most common is adenocarcinoma because it is the cell from which they arise. Now, if you further look into the subtypes of this, it could be a infiltrative type, or it could be a nodular type, or it could be a papillary type. There are papillary projections, of which the infiltrative type is most common and papillary type is least common. And this papillary type has better prognosis. In infiltrative type, it spreads subserosally. And when it spreads subserosally, it has the potential to involve the portal vein or the hepatic artery early. That is why it has the worst prognosis. Now, nodular is in between these two and it has a circumferential spread. When it spreads circumferentially, it is most likely to involve the liver. Right? So, the subtypes are infiltrative type, nodular type, papillary type. Infiltrative is most common, worst prognosis, spreads subserosally, can involve portal vein and hepatic artery early. Nodular type has a circumferential spread, circumscribed spread, and can go to the liver early. And the papillary is least common, but it has got better prognosis. Clear? Hello.
Yes, sir.
Now, how does it spread? The most common route of spread of gallbladder is a direct spread, but it can also spread through the lymphatics and it can spread because it is in the peritoneal cavity, it can have a transcoelomic spread. But the most common route is a direct spread. So directly it spreads to the liver. So from gallbladder to liver, there are two pathways by which it can spread. One is the reason for the gallbladder to spread directly to the liver is the first thing, it has a very thin mucosa. Second, there is no submucosa in gallbladder. Third, the muscularis propria layer is a single layer. Unlike elsewhere in the GI where there are two layers, three layers, it is a single layer, right? And fourth reason is where it is attached to the liver, there is no serosa. It is covered by serosa, but no serosa where it is attached to liver in the GB fossa. There is only a adventitial tissue which separates the gallbladder from the liver, which is actually the plane of dissection for the gallbladder from the bed of the gallbladder. So there is no serosa, which is called a cystic plate. So there is no serosa where it is attached to the liver. So these are the factors by which it spreads immediately to the liver. So one is the presence of thin mucosa. There is no submucosa. Muscularis propria is a single layer and there is no serosa where it is attached to the liver. That is why it spreads to the liver directly. But it can also spread to the liver via the venous route. The venous drainage of the gallbladder is eventually into the liver. So it is both hematogenous spread to the liver via the venous route. Also, it is the direct spread. by which it spreads into the liver, although this is most common. Second is lymphatics. So if there is a common hepatic duct to which comes the common cystic duct, which becomes a common bile duct, and which eventually drains into the CBD. So here is a gallbladder. So this gallbladder, first lymphatic that is involved is a cystic lymph node of Lund. So cystic lymph node is the first lymph node involved. From here, it spreads to the lymph node. This is a cystic lymph node that is involved. From here, it spreads to the lymph node on the either sides of the CBD, which is pericholedochal. Then there is a right hepatic artery. So there are lymph nodes around the right hepatic artery. So it goes to the lymph nodes around the right hepatic artery. Then beneath the duodenum, there are retroduodenal lymph nodes. So it goes to the retroduodenal lymph nodes. Now these four lymph nodes are called as regional lymph nodes for the gallbladder. So the first draining lymph node is a cystic lymph node of Lund. From there, it goes to the pericholedochal lymph nodes, then the right hepatic lymph nodes, and the retroduodenal lymph nodes, which are the regional lymph nodes of the gallbladder. So when it means regional lymphadenectomy, it means that these lymph nodes should be taken. So from there are pancreaticoduodenal lymph nodes. So next, it goes to the pancreaticoduodenal lymph nodes. Then it ascends upwards to what is called as celiac superior mesenteric lymph nodes. It goes a little upwards and drains into the celiac lymph nodes. And then it goes little upwards and finally into the aortocaval lymph nodes. So this is the path of spread of the lymphatic spread of the carcinoma of the gallbladder. So it goes to the cystic, then either right hepatic or pericholedochal, then it goes to the retroduodenal, which all these are regional lymph nodes. Then it goes to the pancreaticoduodenal, a little above superior mesenteric, a little above celiac, then finally into the aortocaval group of the lymph nodes. Clear?
Yes, sir.
Then when it spreads in stages. How to stage this? So TX is where the tumor cannot be assessed. T0 is there is no evidence of the primary tumor. TIS is tumor in situ. Then there is T1, T2, T3, T4. T1 means the tumor is restricted either to the lamina propria or muscularis propria. Right? So if it is restricted to lamina propria, it is T1A. If it is restricted to muscularis propria, it is T1B. It does not pass beyond muscularis propria. In T2, between the muscularis propria and the serosa, there is a connective tissue, which is called as perimuscular connective tissue. So it stays in the perimuscular connective tissue, not at invading serosa. Serosa is not at invaded. So there is a lamina propria, which is invaded in T1A. Then it goes a little further and invades muscularis propria, which is T1B. Then there is serosa, but the serosa is still not yet invaded. So this is what is T2, which is perimuscular connective tissue. Now in this perimuscular connective tissue, if it is invading the peritoneal side first, it is considered to be T2A. If it is on the liver side, it is T2B. Makes sense because peritoneal side is covered with serosa. It has still one layer to go to reach the liver. But here there is no serosa at the liver side. It can directly, next stage here is it can directly go and infiltrate the liver. But here the next stage is it has still serosa to infiltrate. That is why peritoneal side is considered to be T2A and liver side is considered to be T2B. And T3 is where it invades through the serosa. And through the serosa, it can involve the liver, or I mean, without cirrhosis also, if the cirrhosis is invaded or the liver is invaded, colon is invaded, duodenum is invaded, stomach is invaded, anything, that is T3. T4 is the main portal vein. Even if the portal branches or the hepatic artery branches are involved, it comes in T3 only. But the main portal vein or the main hepatic artery, right hepatic artery or the left hepatic artery are involved, or more than two, two or more than two extra hepatic sites are involved. Meaning, apart from liver, any two are involved. So this is T4, right? So T1 is only lamina propria T1A, T1B is muscularis propria, T2 is it remains in the perimuscular connective tissue. If it is on the peritoneal side, it still has one layer to go, so it is considered as lesser stage, T2A. If it is on the liver side, it can directly go into the liver next, so it is T2B. So if it is going into the serosa, involvement of the serosa and any other organ, it is T3. The main portal vein, main right hepatic artery or the left hepatic artery, or any two extra hepatic sites, it is considered to be as T4. Clear? So NX is lymph node cannot be assessed. N0 is no lymph nodes, regional lymph nodes. N1 is 1 to 3 lymph nodes are involved. N2 is 4 and more than 4. Then the MX is no metastasis. M0 is METs is present. M0, sorry, it cannot be assessed. No metastasis. Clinical evidence of metastasis is present. So this is about the staging. So we need staging so that a little difference in the treatment aspect is there. So that is why you need to know at least the TNM staging of this, right? And the stages are not required. Staging per se. Next is how do the patients present? Clinical features. So most of these patients are asymptomatic because a stone in the gallbladder cannot produce a symptom unless it is obstructed. A tumor in the gallbladder can also produce symptom unless it is obstructing. So when this tumor comes and obstructs, the patients will have biliary colic. When it leads to infection, the patient presents with symptoms of cholecystitis. But most of the patients present in advanced stage, where there is jaundice, where there is anemia, where there is weight loss, where there is a palpable mass in the right hypochondria, right? So this is the presentation at the advanced stage. So when these patients present, and you want to investigate the patient, what would be the first investigation that you want to do? Anybody? Hello.
Ultrasound.
So ultrasound is the first investigation where you do. Here you can see that the gallbladder wall is irregular. And then there is some heterogeneous mass inside. Just give me a second, guys. Hello, hello.
Hello, sir.
Uh, So, in first, when you do ultrasound, you get a irregular GB ball, and along with that, there is an heterogeneous mass. But what do you think would be the investigation of choice? Hello.
CECT.
So, CECT abdomen is the investigation of choice because in CECT abdomen, anywhere in the abdominal cases, one thing is you get to know about the tumor. Second is very important, the lymph node status. And the third most important thing is vascular involvement. Right? So anywhere in any tumor in the abdomen, these three are very important. One is the tumor per se, second is the lymph node per se, and third is the vascular involvement. In other words, it tells you about resectability and operability. Anyone can tell me the difference between a resectability and operability? Hello, hello. So resectability is with respect to the tumor per se. For example, here the tumor is gallbladder. As long as gallbladder is involved, it can be removed. If liver is involved, majority of the liver, if there is a limited liver involvement, it can be removed. But if liver is involved extensively, then again it becomes a non-resectable tumor. If the colon is involved, it can be removed. Duodenum involved, it can be removed. Stomach involved, it can be removed. So resectability meaning the structures where the tumor has involved can be removed. That is resectability, which is with respect to the tumor per se. Non-resectable tumor, especially for example, if there is a vascular involvement, if there's portal vein involvement, hepatic artery involvement, if it is more than 180-degree involvement, then it becomes difficult that the reconstructions of these structures become difficult, then it becomes an unresectable tumor. So resectability is local ability to of the tumor to be resected locally. Operability means the patient cannot be operated at all. So operability is with respect to the patient per se. So, for example, if the patient is a poor surgical candidate or he has a ASS score of grade 4 or grade 5, or if the patient is not fit for general anesthesia, if the patient has malignant ascites, or if the patient has diffuse peritoneal mets, then this patient cannot be operated at all. So that is operability. So remember, resectability is with respect to the tumor per se, and operability is with respect to the patient per se. So now CCT abdomen is a very good investigation to know the resectability and operability because it tells us about the tumor, lymph node, and vascular invasion. Now, if you want to know about the biliary anatomy, what do you prefer? Hello,
MRC.
MRCP is the investigation. And you want to know if there is any metastatic disease in the body, the investigation would be
PET
PET
scan.
scan. Now, if you are doubtful about the diagnosis, you can have a diagnostic laparoscopy to see especially the if there is any ascites or any peritoneal mets, what extent of liver is involved. You can have a diagnostic laparoscopy, which also helps in doing a staging laparoscopy. Now, should a biopsy be done or not? Before that, what would you want to do in a blood investigation? Anybody?
CA 1990.
So the you can get if the patient has presented to in the advanced stage, it is all non-specific because the patient will have obviously if there is jaundice, there is a raised total bilirubin and there is reduced HP and some SGPT, SGPOT elevations are there, which are non-specific. A little more specific, where 80% of the cases the tumor markers are elevated. Right? These tumor markers are not that highly specific, they are okay. That highly sensitive, they are okay. So 80% of cases, one is CEA and CA19-9, right? CA19-9 of more than 37.5 and CEA of more than 5.7. So most likely suggestive of this hepatopancreaticobiliary disorders. So that will tell you only the hepatopancreaticobiliary, not just pinpoint the gallbladder cancer. So these are the investigations, pattern of investigations that you can get done. So but always for confirmation, the gold standard is a biopsy and histopathological examination, because unless you see the cancer on a slide, you cannot tell that it is a malignant disease. Now, do you want to get a biopsy done or not? Anybody?
No, sir.
Yes, very good. So you get all the investigations done, which
No,
includes
sir.
radiology. Yes. So you get a radiological plus hematological investigation is done. If it is suspicious of malignancy, you stage the disease. And once you stage the disease, if it is of a early stage and it is a operable tumor, you do not do biopsy. Biopsy is contraindicated because transabdominal biopsy leads to seeding at the site of the biopsy, and you will convert it into a stage 4 disease. So if it is operable, do not do biopsy. If it is non-operable, meaning there is presence of extensive hepatic involvement, there is malignant ascites, peritoneal mets are present. So these are all non-operable diseases. So peritoneal mets is already stage 4. So then to confirm the disease, you get a biopsy and put the patient on palliative care. And if performance score is good, you can start the patient on chemotherapy, right? If performance score is less than 60, Kornowski score is less than 60, you cannot do chemotherapy in any tumor for that matter. So if it is operable, biopsy is contraindicated. If it is non-operable, to start chemotherapy to the patient, you need a tissue diagnosis for which biopsy has to be taken. So these are the things which tell that it is a non-operable tumor, right? Now coming to the treatment. How do you want to treat? The patient can present with a GB polyp, or the patient can present with a pre-operatively diagnosed case of carcinoma of gallbladder, or for some benign disease, you did cholecystectomy. But post-operatively, you sent it for HP. Now, this is suggestive of malignancy, right? In preoperative diagnosis, the patient can come in a early operable state or in a advanced state. When it is advanced state, only thing that you can do is you can give a palliative care. So these are the scenarios in which patient can present. So if the patient has only GB polyp, I told you the management is same. If it is more than 1 centimeter, go ahead with lap chole. If it is less than 1 centimeter and the patient is negative for primary sclerosing cholangitis, you do a surveillance. If it is positive for primary sclerosing cholangitis, you go ahead with a lap chole. Then do the histopathological examination. If he has come in the advanced state, where you can give only palliative care, you can palliate pain, you can palliate jaundice. So to palliate, and you can palliate obstruction. Now the obstruction is because it is involving the pericholedochal area, it can also lead to the obstructive jaundice, and it is involving the retroduodenal nodes or the paraortic nodes. It can also cause the bowel obstruction, especially the stomach obstruction. So you put a stent there to relieve obstruction. For jaundice, also you can put a stent in the CBD. For pain, is always a step-up management. You give NSAIDs, which does not work. You switch to opioids. Opioids also does not work. You can give a celiac axis block. This is how you manage if he is coming to you in an advanced state. Now, what to do if the patient comes in early stage and Preoperatively, all the investigations, there are tumor markers are raised, and all the CT, MRI are suggestive of malignancy. So if you diagnose it preoperatively and the patient is operable, you remove the gallbladder, which is cholecystectomy. Plus, because the gallbladder has a higher tendency to involve the liver, you check for liver infiltration. If liver is not at all involved, then you do what is called as wedge hepatectomy, wherein in the gallbladder fossa, 2 centimeter of margin of liver is removed. If there is involvement of liver, even if there is a slight involvement of liver, so if this is the liver, so when you divide it into segments, this will be 2, 3, 4A, 4B, 5, 6, 7, 8. And here is the gallbladder. So you remove segment 5, segment 4B. So if liver is involved, infiltrated, remove segment 5 plus segment 4B. Along with that, you do a regional lymphadenectomy. What are regional lymph nodes? Hello. Cystic, pericholedochal, right hepatic artery, and retroduodenal. Right. So these are the lymph nodes. This is the complete treatment. You do a cholecystectomy with regional lymphadenectomy. And if the liver is not involved, you do wedge hepatectomy with 2 centimeter margin. If the liver is involved, you do a segment 5 and segment 4B resection. And then you send the procedure, you send the specimen for intra-op frozen section. And in intra-op frozen section, you need to look for CD margin. Cystic duct margin is negative, you can stop there. But if there is a cystic duct margin positive, then you go ahead with CBD resection also. And then do a bilioenteric anastomosis, which is nothing but hepaticogystostomy, right? So you remove GB, regional lymph nodes, and liver, either wedge hepatectomy or removal of segment 5 and segment 4B. Send for intraoperative frozen section. If CD margin is negative, you stop there. If it comes as positive, do a CBD resection and a bilioenteric anastomosis. Is this clear? Hello.
Yes, sir.
Then is what if there was a benign disease preoperatively and you did a cholecystectomy. You send the specimen for histopathological examination, and histopathological examination came as malignant. So that is why it is important to follow up all the histopathological examination of any tumor that is removed. So if it comes as malignant, you see for two things. First is only mucosa is involved. It has not spread to the transmural layer. Right? Only mucosa is involved. And second, the cystic duct margin is negative. Right? Both of them should be positive. Right? Both of them should be there. If both of these are there, you don't need to do anything. You can just stop there. Right? But if it is any one of these is positive, either there is a transmural spread or the cystic duct margin is positive, then you need to do what is called as radical en bloc resection. That is what this is, right? So this is what is radical en bloc dissection. You go ahead, you post the patient for surgery. Already gallbladder is removed. You remove the depending upon the liver resection, liver involvement, you either remove the 2 centimeter margin or you do a segment 4B and segment 5 limited liver resection and lymphadenectomy and examine the lab port site. If there has been deposits at the lab port sites, then he becomes a candidate, he or she becomes a candidate for the adjuvant chemotherapy. Right. Earlier, they used to do resection of these lab port sites, but now that is not needed. You can send them to adjuvant chemotherapy. Now, what are the, you are clear with this, right? Hello?
Yes, sir.
Now, what are the indications for adjuvant chemotherapy? Meaning, after surgery, when do you need to give chemotherapy? Most of the times, these indications remain same for any tumor, right? So, if it is a T4 disease, if it is a disease where the lymph nodes have become positive and there is a R1 resection, right? So R0 resection means you excised a tumor both microscopically and grossly. If it is negative, it is called as a R0 resection. R1 resection is grossly the tumor margins are negative, but microscopically it will be positive. That is R1. R2 resection is literally cutting through the tumor. Grossly only the margins are positive, right? So if there is a R1 resection, if the lymph nodes are positive, or if it is a T4 disease, or post cholecystectomy, port site involvement is there. You give adjuvant chemotherapy in the form of capecitabine, or it can be combined with capecitabine plus gemcitabine, or it can be combined with capecitabine plus platinum based therapy, cisplatins. Right? This is all about carcinoma of the gallbladder. Is this clear?